Hello friends, welcome to the educational series of Love You Zindagi. Today we will start with indirect pulp capping.
Direct pulp capping, a procedure wherein a small amount of carious dentine is retained in the deep areas of the cavity to avoid exposure of the pulp, followed by placement of a suitable medicament and restorative material that seals off the carious dentine and encourages the recovery of the pulp. As we all know, any procedure has its own indications and contraindications. The indication of indirect pulp capping are as follows. First, you need to take the history. There has to be mild discomfort from chemical and thermal stimuli, and there has to be an absence of spontaneous pain. In the clinical examination, what do we see? We see a large carious lesion, absence of lymphadenopathy, there is normal appearance of the adjacent gingiva, and the tooth color is also normal. On the radiographic examination, we see a large carious lesion in close proximity to the pulp. There is normal lamina dura, there is normal periodontal ligament space, there is no interradicular or periapical radiolucency seen. Now we will talk about the contraindications. The patient will give a history of sharp, penetrating pain that persists after withdrawing the stimulus. Prolonged spontaneous pain, which can be present during the night time. On the clinical examination, we can see there is excessive tooth mobility. There is parallus in the gingiva approximating the roots of the tooth. There can be tooth discoloration present and non-responsiveness to pulp testing techniques. On the radiographic examination, we see a large carious lesion with apparent pulp exposure, interrupted or broken lamina dura. There is widening of periodontal ligament space, and there is radiolucency at the root apices of furcation areas. When we see all such things, we do not go for the procedure of indirect pulp capping. What are the traditional materials which we use for indirect pulp capping? There are two of them. One is the calcium hydroxide and second is the zinc oxide eugenol. Calcium hydroxide, its mode of action is to serve as a protective barrier for pulp tissues, blocking patent dentine tubules and neutralizing the attack of inorganic acids and their leached products from certain cements and the filling materials. There are a few advantages of calcium hydroxide. It is initially bactericidal and then it becomes bacterostatic. It promotes healing and repair. It gives a calcium bridge formation. It helps in the formation of reparative dentine and it also stimulates odontoblastic activity. Things do come with disadvantages too. Similarly here, what are the disadvantages of calcium hydroxide? It does not exclusively stimulate dentinogenesis. Coagulation necrosis takes place. There is lack of addition to hard tissue, inability to provide adequate seal against microleakage, and it dissolves under restorations. Now we come on to the zinc oxide eugenol. Its mode of action is demonstrated by the sedative effect it has on the exposed dentine. Zinc oxide eugenol cements are supposed to be the least irritating of all the dental cements and are known to have an anodyne. What is anodyne? Anodyne is a soothing effect on the pulp in deep cavities and this helps to reduce the pain. What are the advantages of zinc oxide eugenol? It is bacteriostatic, it has good sealing properties, it has very mild pulpal responses, It has an obtundant effect and it's least irritating to any tissue. Disadvantages of zinc oxide eugenol: it produces chronic inflammation, it lacks formation of calcific barrier, it does not chemically adhere to the tooth structure, and it has the highest solubility in oral fluids. What are the treatment procedures? How you perform this procedure of indirect pulp capping? There are two types of techniques. One is a one appointment technique and the second is a two appointment technique where you have to give two sittings to the patient. The treatment in the first appointment, you need to give the local anesthesia and isolate the tooth with the help of a rubber dam. Establish an outline form with a high-speed burr. Remove the superficial debris and majority of the soft necrotic dentine with slow speed handpiece using large round burr. Care must be taken to avoid the pulp exposure. All caries except lying over the pulp has to be removed. Stop the excavation as soon as a firm resistance of sound of dentine is felt. Peripheral carious dentine is removed with a sharp spoon excavator. The cavity is flushed with saline and dried with cotton pellet. The site is covered with calcium hydroxide and is filled with zinc oxide eugenol. If there is the remaining tooth structure which is insufficient to retain the temporary filling, a stainless steel band or a temporary crown must be adapted to the tooth to maintain that filling. This is how we can appreciate the carious lesion in a tooth and how we give a base or we just cap the pulp stump with the help of calcium hydroxide, and then the remaining restoration, that is the temporary restoration of zinc oxide eugenol, is done. Now in the second appointment, the patient comes over after about 6 to 8 weeks. Between the appointment, the history must be taken first so that we can rule out any sign or symptom of pain or any pathology present. We need to take a radiograph and see that there is no pathological lesion that has been formed. The treated tooth is re-entered after 6 to 8 weeks. Again, you take a bite-wing radiograph and observe for the sclerotic dentine. Then carefully remove all the temporary filling material. On re-entering, caries will appear arrested, flaky, and dried out. The color will change from deep rose red to light gray and to light brown. The texture will change from spongy and wet to hard. The cavity preparation is washed out and dried gently. Then you cover the entire floor with calcium hydroxide. The base is given and the final restoration is placed. This is one of the cases we did in the department after IPC and then post-operative, that is 6 to 8 weeks after IPC. We can very well appreciate that there are no changes in the periapical area in both the radiographs.
I hope this lecture helped and I am available to answer all your questions.